Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today I am joined by Dr. Hal Stewart. Dr. Stewart graduated from Baylor College of Dentistry in 1989 and has been in private practice in Texas ever since. He's an affiliate of the Breathe Institute, where he also serves as a teaching faculty member and was inducted into the American College of Dentists in 2018. Dr. Stewart is the co-founder and CEO of the Stewart Center for Minimally Invasive Dental Medicine, and he lectures extensively, teaching dentists across the country and even around the world on craniofacial growth, airway, breathing, TMJ, and restorative dentistry. He believes that a healthy airway and a healthy mouth with stable joints and harmonious occlusion are imperative to one's overall health. Dr. Stewart also is a fellow podcaster and hosts the Health and Harmony Beyond the Teeth podcast, which I was recently a guest on, and he does a great job with the show. Hal and I have a great discussion about what holistic dentistry is and how it differs from traditional dentistry, how and why he ended up getting into airway-focused orthodontic and dentofacial orthopedic treatment for his patients, the importance of diagnostics and the 5 regions he looks at in every patient, why all dentists should evaluate airway as a potential contributing factor to our patient's malocclusion, how airway impacts posture and TMD, the importance of working with our medical colleagues if and when an airway issue is detected, and much, much more. As many of you know, people feel very passionate about the topic of airway-focused treatment and have pretty strong opinions on one side or the other. I think you're going to enjoy this conversation between the two of us, because ultimately it gets at how we do better for our patients. And I really do believe that is something we are all striving for. And my view is if we can just keep that in mind, that we're all doing this to try to be the best docs we can be for our patients, that will help break down some of those walls and barriers and help us have these discussions across disciplines within our field. So without further ado, let's get on to today's episode with Dr. Hal Stewart. Enjoy the show, everybody. Welcome to Doc Podcast, Hal.
Hey, nice to be here. Thanks for having me.
Thanks so much for coming on. We met back in the fall at Airway-Palooza, which was a great event. Lauren always does such a great job with that. And we got talking after I spoke that one second morning and just kind of realized we had a lot of things in common and a lot of shared values, so to speak, on how we approach patient care. And we'll talk a lot about that during today's show. If you would, and also as a fellow podcaster, I've been on your show as well. So you know what it's like to sit on both sides of this camera, which is always fun. But if you would, before we start, just tell the audience a little bit more about who you are and how you got to the point you are in your life and career today.
Okay, well, thank you. I'm Hal Stewart. I practice north of Dallas in a community called Flower Mound. I used to say a small community, but it's not small anymore. It's growing. Nielsen, Texas. But I started my practice I graduated from Baylor College of Dentistry in 89, started my practice on my own in 90. So I built a new building in 98. So I've been practicing in that area for 36 years now. And I started my practice a little bit different than most dental practices. I started it out as a very low volume, comprehensive type restorative practice. And my father was a builder and he built one house at a time. Mm-hmm. Maybe 3 houses a year at the most, usually about 2 houses per year.
Wow.
And he was there every step of the way. He might have subcontractors doing different jobs, but he was there overseeing it every step of the way. So from an early age, I had a business model of doing things on a personal level and doing things very thorough and doing them right. And so when I went to dental school, I actually loved the fact that we actually brought patients in. We did a consultation with them. We brought them back for an exam and records. We got all the records together. Then we met with them again and proposed a treatment plan. And I remember the first treatment plan I presented in dental school, I think it was $1,200. In middle school money, you can get a lot for there. You used to could. That was that was a lot of treatment for $1,200. I was scared to death, and the patient accepted, and went from there. So when I got out of school, I started a low volume practice, just seeing. Our goal was to see one new patient every day. So and we worked 15 days, so about 15 new patients a month, and that would allow me to look at everything from I'm not going to say a holistic in with the HOL. At that time, it was looking at the whole patient in a holistic environment as from how the mouth relates to that. So back then, it was doing a thorough periodontal charting and checking the gum tissues, and then looking at the bite in the TMJ and all of that. So I went through the Pankey Institute, which is a higher learning education for dentists that really teaches that type of dentistry and doing things, from the beginning very accurately and looking at the whole mouth and not just teeth. And so my practice thrived doing that, and I had, pretty much stayed with that one new patient a day. Probably never really met that goal. It was more like maybe 2 new patients a week, but still, it was a great way to practice. And I'm referring that into the past because, as I'll get to, my story has changed for a reason. I thought that I was doing things, I was getting to the root of the problem when people would come in with worn teeth and teeth that were being, loose and they needed to be taken out. And I thought I was going to the root of the problem because I was looking at their gum tissue and then stabilizing their jaw joint and then rebuilding their occlusion, and did that very successfully. Then I learned about Airway in probably the late 2000s, 2008, 2009. And one of the reasons why is my father died of Parkinson's, and he had severe sleep apnea. And I remember going to visit mom and dad, and they had a little small house out in the country, and they had a loft, and we would sleep up in the lofts. They had beds up there, but you could hear my dad, literally raising the roof, snoring. And at the time, we would kind of joke about it, and it's, oh my gosh, we're gonna wear, put a pillow over my head so I don't hear him snoring. But I would remember counting sometimes almost to 60 seconds. He would stop breathing, and then he would gasp. Wow. And then he, just suddenly over a couple of year period went from this very, very healthy, thriving, he was a big guy, and I just saw him deteriorate. And I have no doubt in my mind at the time, they weren't really putting airway and Parkinson's and dementia and all that together. Right. But even then I thought, his sleep apnea I know it had something to do with this. And so that's a very personal story on my end, is why I shifted my focus, still doing the restorative dentistry, but looking at further, down in the roots of the tree as to what the problem is. And so I've got a great graph that I show my patients. Small jaws lead to malocclusion. Malocclusion leads to clenching and grinding. Clenching and grinding leads to TMJ disease. That side of my flow chart I've always known. But small jaws also lead to a restricted airway, and that can lead to interrupted sleep, that can lead to fragmented sleep, which has a whole list of comorbidities as well. So when I first realized that, the jaw size has something to do, if not everything to do, with the way people breathe. And you start hearing medical doctors talk that are really airway focused, you start learning that it is truly a multidisciplinary issue. And it's not just about growing jaws. Although if a person has underdeveloped jaws, that's one of our goals, is to do that because they're just going to benefit from it. But it's not only the jaws, it's not only the teeth, it's not just the tonsils and the adenoids. In our practice now, we started seeing airway patients about 12 years ago, and just a few at a time. And as our reputation grew that we were doing that, we started attracting patients that are looking things from a more of a holistic view. And we started with adult patients only. I went through all the Vivos courses and learned how to use epigenetic appliances to expand jaws and to, remodel airways. Never, ever do I tell patients I'm treating their sleep apnea. I never tell them that. That is not my scope of practice.
Yep.
What I do is remodel their jaws and remodel the airway to an extent. And sometimes they don't have sleep apnea anymore, and sometimes it lessens the sleep apnea. But as a airway dentist, I never claim that I'm treating that. If I do have a patient that just wants a device to hold their jaw forward, I work with physicians and I make that appliance for them. But I try to stay away from those because I really want to try to treat things, so they're breathing good all the time, not just sleeping and with a device. So I'm a big believer in CPAPs. I'm a big believer in anything that can help you sleep. Does it mean that, I have a lot of patients that are on CPAPs that want to get off of them. And so I just tell them, let's remodel your airway and see where you are. This may or may not get you off your CPAP, but one thing that I can tell you, it's going to help you breathe better all the time. But as you and I were discussing earlier, there are, we work with body workers, craniosacral specialists, upper cervical specialists. We work with ENTs, maxillofacial surgeons, internal medicine physicians, osteopaths, because the body is all connected. And when you see somebody that comes in that has an airway issue, our realm is right in here, but that can have an effect all the way down the body. So we're not just throwing appliances in people's mouths and expanding their jaw. I would say the average adult patient that we have, and children as well, are probably working with us as well as at least 3 to 5 other healthcare professions, myofunctional therapists. All of our patients see a myofunctional therapist. All of our patients see a craniosacral therapist. Many of them have to see the ENT. And I've been fortunate enough in Dallas to have a few ENTs that are really on board with the airway. And they also understand that just taking out adenoids and tonsils is, sometimes they need to come out. There's no doubt about that. But they also understand that that's not always the case. As a matter of fact, most ENTs don't really like to take out tonsils.
True.
It's just, it's a pain for them to do it, literally, because they don't get paid for it, really. And it's a fairly high risk procedure, and there's a lot of maintenance. And so we try to avoid, when we can, doing that. So one thing I really have enjoyed doing as a dentist, we want to get in and we want to do something in the mouth.
Yes.
So from an early career, early in my career, I at least helped, I'd kept the brake on until I'd done a complete diagnosis and met back with the patient. But then I was chomping at the bit to get in the mouth. Now, what I really, really enjoy is sitting down with a patient and going over everything that I see that is in my realm and things that aren't in my realm, but I know they're there. Like, I know someone has a deviated septum. I'm not going to make that diagnosis, but I can show them your septum is deviated. Here are some of the ramifications of that. Let's get you over to our ENT, have them take a look at you. And it truly is a multidisciplinary team approach. And when I tell people about my team, I include the ENTs, the maxillofacial surgeons, the myofunctional therapists, because we're all there. We're not all in one building. They're together, obviously, but I can't do everything that I need to do for the patient without their help, and vice versa. So I think an open dialogue with other professions is extremely, extremely important. And so that's kind of in a nutshell, the history of how I got to where I am now. I've always been a teacher. Probably starting 5 years after dental school, I started teaching. I was invited to teach some different supply companies, dental supply companies, tagged me as a KOL, a key opinion leader. And so I've had the opportunity to teach, and I love teaching. And I started my own teaching center in 2014 with two partners, and we kind of went our separate ways on a very good note. No issues there. And I changed the name to the Stewart Center in 2000, I believe it was 17. Okay. And what we teach is TMJ stabilization and how TMJ issues relate to airway. I'm not really teaching how to treat airway with the expansion devices and things like that, because there's guys like Ben Moralia and that, well, and other Vivos and Dr. Felix Leal, they've got a handle on that. I tell my doctors, if you specifically want to learn how to use these appliances, go to Ben, go to Felix. What we teach is basically the putt in the golf game. So that means stabilizing the bite after the airway's been remodeled and the patient's feeling better. So that's what we teach. I'm debating on whether to continue my teaching center, just because I want to spend as much time as I can with our patients. So we're going through a big remodeling process in our office right now, and so we can accommodate more patients, because, and I think when we talk a little bit later about different communities in our profession that kind of sometimes throw fireballs at us for doing what we're doing. There is such a need for what we do. There's not enough doctors, dentists, orthodontists combined to treat the patients that need what we have. So there's not a competition issue out there at all. I've never felt that way at all. But when we started seeing children about 8 years ago, as you know, you're an orthodontist, and I know you see children. You have to have a bigger waiting room than I had. I had a waiting room with 3 chairs in it, because for years I just saw one patient at a time.
Right.
So we're remodeling now. So, at 65 years old, I feel like I've started a second career, and I love it. So that's kind of where my journey has led me. I still enjoy speaking. I still go to continuing education, probably 200 or 300 hours per year, because I just love learning, and there's so much to learn. So, hearing you speak at the Airway-Palooza last fall was amazing. I love listening to people like you that come and they present, and they have good hard data that they're showing, and they're not just up there to put on a show. And that's why you got a standing ovation. You're the only one all week that got that. And there are some great speakers, but I love learning, and I love doing these podcasts. I have my own podcast, and I have a lot of patients that follow it, that they'll say, I heard you interviewing Dr. DeLuke or whoever, Felix Leal, and boy, I really learned a lot. And so that makes me feel really good, because we need to educate the community. That's what the medical profession is doing now. The drug companies, they're advertising on TV. Yeah. They're not advertising to doctors anymore. They're advertising to the general public. And I'm not real big on pharmaceuticals, but I think that approach is what we need to be doing, because people are looking for this, and people understand it, and they're not dogmatic in their thinking like a lot of the people in our profession are. And it's not their fault. We're taught a certain way, and but like Dr. Struzagi says, he said when he graduated from medical school, one of his professors said, in 5 years, 50% of what you learn will be obsolete. And I believe that with that trend, you've got to keep and stay on top of things. So that's where we are now. I practice with my wife, Dr. Adriana Corridor, and we were able to help a lot of patients, adults and children alike.
That's awesome. Thank you for going through that. Thank you for the kind words too on the talk, and I love doing that. It's a huge passion of mine, and you are a great educator, and you clearly understand the concepts from both a macro and micro perspective. And I think that's what's missing. A couple of things you said that I really am so happy that not only you said them, but the way you explained them. And I just want to kind of drill down on them a little bit. One is this concept about dental school versus practice, right? Dental school and our training and residency as well in ortho, so much time is spent diagnosing and treatment planning. And we get out into practice and we're looking for ways to minimize our diagnostic and treatment planning time, because we just want to be, as you said, doing procedures.
Yeah.
And that to me is a fundamental problem with our profession. And it's something people like Pankey and Dawson, right? If you look at their literature, I've never attended either course, but fight against them. And John Coyce, they fight against that. They're trying to get people to be better diagnosticians. And that is one thing I constantly am pushing residents and docs I coach and train to do, is to not abandon the concepts of diagnosis that are the fundamentals and the bedrock of what we do. And you use the example with your dad as a builder, right? He was clearly analyzing and building and constructing things that would last. And right. You could throw, but look at today, how many homes are just thrown up, right? Yeah. And it's common. You have people who buy a new home and they have nothing but problems with it.
Yeah.
Constantly. Why? Not because they didn't know how to build. Right? The actual building process has been very standardized, and we're talking kind of most homes, right? We're not talking unique sort of design or architectural design for the average sort of standard home. It's the planning. They didn't actually plan the process outright. So they cut corners and missed things because there wasn't somebody creating a good plan and executing it appropriately. And I feel we're doing the same thing in our field. I think ortho is really guilty of that. And I know a lot of my orthodontic colleagues, many listen to this show, don't love when I say that. Yeah. I look at it as it's my responsibility, and I said it when I was on your show, to call balls and strikes on this stuff. And ultimately, where do orthodontists make our money? In the clinic straightening teeth. Any consultant will tell you that. Get in the clinic where you belong. Don't waste time in the consult room. You're trained on this. You know what you're doing. How many class 2s do you need to see before you know what you're going to do with it? How many class 1 crowdings do you need to see before you know what you're going to do with it? 2-3 minutes in that room, get back to the clinic where you make your money. And here's the thing. Maybe on 80% of your patients, they're right. Maybe. I don't think it's that high, but let's just go with it, right? You're totally misdiagnosing 20% of your patients minimum. Totally missing it because you don't know the underlying etiology. And I know people think, well, the etiology, it's genetics. It's not all genetic. As you said, it's epigenetic. There's a lot of environmental factors. It goes beyond what we can get into today. The point being, there's not like one cause of all of these different types of malocclusion. And you said very well, I want to reference it as well. It's the effect of small jaws and what small jaws do to malocclusion. And you had this understanding that it caused malocclusion and even TMD in a lot of patients. But then because we get zero training on the airway side, sadly, even today in most places, it took you a lot of years of practice and then having a very intense personal experience with your father to start to think differently about this and go, wait a minute, maybe I can play a role in this. Maybe I am more than just someone who in your profession is restoring teeth and balancing jaw joints and sort of that somatic gnathic system, right? Working in that. Maybe there's more beyond that. And in our profession, it's the same thing. The talk I just gave recently at the Florida Association of Orthodontists annual meeting, the underlying theme of that talk, it was a 3-hour presentation. The underlying theme was that we have what I call straight teeth bias. We are trained in a world to see nice, perfect, class 1, ideal overbite overjet models on a table. Mm-hmm. That's how we're trained. I'm turning 50 here soon, but I'm not that old. I trained still. When I took my boards, I flew down to Dallas, Texas, ironically, and took my boards down there. I had to fly down with my cases in a backpack or in a bag and set my models on the table. And they never asked me about this patient's health. They didn't even want early treatment. They don't even look at early treatment. They want us to see, can you straighten teeth, right? Straight teeth bias. What you're saying is there's a lot connected to those teeth. There's a lot beyond even the mouth that's connected to those teeth. So talk a little bit, if you would, about when you started to realize that connection more, what that process was like. Because a lot of people may realize this and even acknowledge it, but they don't know what to do about it at that point. And then it starts to feel very overwhelming. It's like, oh my gosh, right? Like now, oh my gosh, I was never trained on this. I didn't look for this. I have all these other patients I'm treating this way and I'm not doing that. Like, how did you do that? And I know it took a number of years, but I guess within that is sort of the underlying question of, if you're a doc out there listening, what would be your advice to them if they're starting to understand this is something they want to do, but they just don't know where to begin?
Yeah, well, to me, it was liberating when I found out that I've been working with teeth in the TMJ and with a high level of success, but still cases that were really frustrating. now I know, and I
sorry to
know.
interrupt for a sec. When you say frustrating, was it like their TMD wasn't resolving, or they were breaking, fracturing crowns or veneers? Like,
Right. Yeah.
Okay.
And so even, when they were restored, they were still, destroying the dentistry that was put in there.
Got it. Mm-hmm.
A high level of success, which in retrospect now I think, wow, I can't believe that we had this many successful cases from a standpoint of the occlusion holding up and everything, because these people clearly, I look back and go, well, they've got airway issue. Mm-hmm. And a lot of my patients that were restored 15 or 20 years ago we're working with them on, epigenetic expanders, and they're going through our whole process, which is great. But I would say this to doctors that want to get into this. I would, there's basically, when you say you're an airway dentist, you're either doing one of two things. You're working with physicians to create appliances that hold the jaw forward so people can sleep better at night. And, it's a treatment and a management of their sleep apnea. And if that's what you want to do, great. You can help a lot of people doing that. A 30-year-old truck driver with 3 kids, he just wants to keep from running off the road and taking out a school bus because he's not sleeping well. So, and maybe that's all he can afford, and that's wonderful. Then you've got the airway dentists that the way that we do it, which is working with a multidisciplinary team and looking at all of the ramifications of their airway issue and all the ramifications that led to the airway issue. Mm-hmm. And that's something that you really have to have a team together. So I would tell dentists that are wanting to get into this that they do a lot of education first before they just jump in and start treating. And one thing that I really loved about Vivos is that they did really emphasize treatment, diagnosing and treatment planning. And I was walking by the room a couple of years ago and heard my wife, Adriana, say to a patient, there are multiple ways to treat things, but there's only one correct diagnosis. And until we know that diagnosis, we don't really know what we need to do. And that really stuck with me. And I use that all the time with their patients, because patients have kind of been programmed to, let's get things going.
Right.
And so I would tell dentists that are doing this, you still have to make a living. So you can really do what I'm doing now by just taking a half a day a week and devoting that time to learning all you can about airway, all you can about myofunctional therapy, all you can about craniosacral therapy, and do that one day a week. And then maybe start scheduling a patient or a half a day a week during that 4 hours. Work at it slowly. And before you know it, you will be gaining confidence in doing that type of airway-focused dentistry. And I would tell doctors this as well, that people are seeking this type of treatment. They're out there seeking this type of treatment. And if you don't understand how, you don't have to be an expert in the entire body, but you do need to know enough to know how, A affects B and B affects C and C affects D. Yep. And it doesn't just stop at the mouth. So become a holistic learner, just learning about anti-inflammatory diets, anything to reduce inflammation in the body. We can really, we see patients really more often than their physicians do. So we can have a big effect on that. And you had said earlier about patients being overwhelmed. They are, and they don't know, I've heard that I need a tongue release, and no, then I heard I need expansion, and then someone said I need to go to a craniosacral therapist, and I'm like, well, yes. So we tell this to our patients. We kind of take pride in saying, well, this is kind of the hub of the wheel. We see all these things, and then we'll send you to where you need to go, and our treatment plan puts it all together. We're not treating all these other issues. And so when we give them a treatment plan, it's got everything in kind of the order that we need to go, and they can take that with them then to their ENT, or they can take it to their internist or their gastroenterologist and say, here's what I'm working with Dr. Stewart and Dr. Corridor on. And, hopefully their doctor will read it. The ones that we work with closely do, because they know us, but, sometimes we get a patient that, has their own ENT or their own. And so sometimes, we have to kind of explain it to their other doctors of what we're doing. But I think that if you want to do something as a dentist or an orthodontist and really treat your patients holistically, you've got to be looking at airway. And there's so much more information out there now than there was 10 years ago. It's great, but we still have a long way to go. And, it's orthodontists like you that are leading the way. Because I know, as a general practitioner, the orthodontists in my community don't really support what I do because I am doing orthodontics. But I've taken the due diligence to learn how to do it and to learn how to do it well. And so, but that's your profession, and I commend you for standing up for what you believe in. And we're not here to put other professionals down. We're just here to speak the truth in what we know, and let the pieces fall where they may.
Yeah, and it's true. It's real. It is a contentious topic. It is a controversial topic in the ortho arena. The fact that there are non-orthodontists doing, and I like to actually say not just orthodontics, dentofacial orthopedics, which is something I speak a lot about, is part of the reason we have straight teeth bias is because we focus on teeth. We don't think of ourselves as dentofacial orthopedists, even though in the mid-'80s was when our journal changed. Dr. Tom Graber changed our journal from the AJO to the AJODO. And in 1994 was when the AAO House of Delegates went to the ADA and lobbied to get our name successfully changed from orthodontics to orthodontics and dentofacial orthopedics. But when I speak, I'll often joke with them with a room of orthodontists and say, how many of you walk in, or when you meet one of your kids' friends, or you're at a dinner party and you meet somebody and where do you do? Where do you work? Oh, I'm an orthodontist and dentofacial orthopedist. I mean, not really what you do and think of ourselves as, because we think of ourselves as tooth straighteners. And what I challenge my colleagues to think of ourselves as is more holistic, whole patient health providers who have incredible knowledge in craniofacial growth and development. And with using appropriate dentofacial orthopedics, we can help young faces especially grow, and even old ones with a lot of the modalities we have now, or even if that involves surgery, right? We're still more of an orthopedic. I mean, orthopedics means straight child in its origin. It was founded by Andry in 1741, the term. It is because they were trying to figure out ways to get children to grow straight. In the textbook, they have a picture of a tree to a pole with rope around it as an analogy. The genesis of dentofacial orthopedics is helping kids to grow straight, if you go purely by the concept. So it is interesting that then, and somewhat ironic, that when many orthodontists see non-orthodontists, or I can personally attest to this, other orthodontists, so don't take it personally that it's because you're non-orthodontist, that might add a little fuel to the fire, but I get just as much incoming speaking like I speak as a board-certified orthodontist. Because it's like they think of themselves as orthodontists. They look at everything from a tooth-based perspective, and it needs to be a paradigm shift. We have to shift our mentality. So in other words, instead of having this argument and a debate over, well, why would you start a kid at 4 or 5, even 6 years old, right? Because the literature says that you can wait and get just as good of a result if you wait and straighten their teeth later. All of the literature is looking at tooth-based parameters and metrics. It's looking, can you still get them class 1? Can you still get good overbite and overjet, right? That's it. It's looking at straight teeth. Whereas when you go and help the face grow, the parameters they're using have nothing to do with biomarkers or airway or breathing or health or the type of sleep the patient is getting, how well adjusted the child is, if they have ADHD, if they have other systemic medical issues. Yeah, not saying every single one of those issues is caused by sleep, but a lot of times they are. And there's no research happening on that. We're just everything. So the orthodontist, there's this sort of mind shift that needs to happen. And that's one of the things I'm really pushing for in our profession, is to try to help my colleagues see people like you, meaning Hal, and your wife and other colleagues who are trying to help their patients in this way, everybody seems to say, oh, they're just doing it for money, or they're just trying to take the patients from the orthodontist, or they wanted to go become an orthodontist and never could, so they're doing it now. And I just call that out because that's a lot of, I mean, I'm not telling you anything you don't know. I'm sure you've heard all of that. Yeah. So, right. I mean, so I look at it and I say, I've never once met a non-orthodontist or orthodontist who started down this path and started looking more into airway and holistic patient care and did it for the money. Because anyone who's done it knows when you start, you don't make more money.
Yeah.
Right? I did this in my practice. I went from...
And you also don't go back to what you were doing.
Right.
Anybody that goes down this path, they see the truth is so evident to them that they cannot go back.
Which is hard. It's hard to, you now have to change your systems and your team training and even down to the literature you give your patients, right? And the scripting for your front end team members. That's the reality. And I call out my orthodontic colleagues all the time and I say, a lot of you just don't want to change that because you have your systems. You're making a lot of money straightening teeth and there's really no incentive to change. And I've never told anybody they have to practice with a philosophy like you have or I have. I've always said, though, where I draw the line is when people mock others who do elect to practice that way. If you don't want to do it, if you just want to straighten teeth all day, fine. I mean, practice how you want to practice. I can disagree with it, but I'm not here to tell you that everybody has to do it like I do it or you do it. Yeah. That being said, when you start making accusations against other people that it's about money or greed or insecurity. Now, I will say, in fairness, there are people, just like in anything, who overdo it and they promote everything as being airway and they treat and they expand every 4-year-old that walks into the office. To me, that's just as egregious and offensive as the person who never helps those kids, because you're still doing one thing in common. And you got back to it with what your wife said. There's only one diagnosis and neither of those people are taking the time to do that. Mm-hmm. They're both throwing a treatment plan at those patients, one being, say, watchful waiting, and the other being go in and treat and expand. And that gives everybody a bad name. So I'm very much against that. Treat everybody. Everybody needs expansion. Like you said it very well. You have to take the time to diagnose. Why is this particular patient struggling, right? And maybe it is lymphoid tissue. Maybe it is allergic rhinitis and chronic nasal inflammation. Mm-hmm. Maybe it is insufficient tongue space and transverse deficiency and high palatal vault and nasal volume issues. Maybe it is a myofunctional therapy issue, right? And maybe it's a combination of every one of those. And so when we don't recognize the multifactorial nature of this and we just start saying this will treat that patient. Another thing, the term airway orthodontist or airway dentist, I don't love the term because I think all dentists and all orthodontists should be aware of airway. Should be part of our name. I mean, that shouldn't be something that we have to differentiate ourselves as, we don't call ourselves tooth filling dentist, right? No, seriously, like a tooth straightening orthodontist. Well, it's almost duplicative. To me, it's in the name. It's in the name of what we do. And I feel like we almost need to, as a profession, say, it's not that those who are focusing on airway are doing more. I think we need to change the way we think and say those who aren't looking at airway as part of this. And again, I'm not saying every patient is airway. What I'm saying is those who aren't looking for it as part of their differential and their diagnostics. We need to frame it so that those people are viewed as not doing enough to be good diagnosticians. What are your thoughts on that?
Well, the ADA came out, I think it was 2015 or 17 with, I don't think it's actually labeled a standard of care, but they recommended that every dentist screen every one of their patients for airway. So
the 2017 position statement.
It didn't the standard of care, which it should be.
Yeah.
So you can't argue with that. That right there, that puts it in our plate that we all should be airway dentists. We all should be looking at that. So the term dentist should be synonymous with, airway. Just like the term, if you're going to a doctor for an exam as a man, you knew, not anymore because they do the PSA, but you knew you're going to get the regular exam for the prostate, but your doctor wasn't called the prostate doctor. You just knew that was going to happen, and we should all be. Or
on that, how the ENT, we don't have an airway ENT, right? We don't have an airway allergist, right?
Yeah. Yeah, it should be as common, and I think it will be one day. It just takes time,
Yeah.
It takes time, and certainly I've seen it change. I've seen more and more, and it could be, people say, well, how many people that come to you have an airway issue? And I'll say, well, probably about 100 because 100% because that's why they're coming to me. Right. Asking an oncologist, how many of your patients do you see that have cancer? Right. Well, it's kind of so if we were all practicing this and if everybody would at least do a screening, and I tell doctors all the time when I lecture, you don't have to treat any of this if you don't want to, but you need to identify it and then send the patient where it can be treated. And I have a lot of referrals from general dentists because they don't want to do it, but at least they're looking at it and recognizing it. And that's very comforting to me that there are more in our profession doing that. So rather than throwing spears at each other, we should be supporting each other. And but humans are humans. That's the way we are. And I think dentists are probably some of the most critical healthcare practitioners out there. All you have to do is go to Facebook and put a before and after picture of a beautiful smile you created, and you'll have 25% of people saying that's beautiful. Then you'll have the other 75% saying, oh, you should have made number 10 a little longer.
Yeah, that one incisal embrasure is not
estimates, or the embrasure is not quite right, and I don't like the color. It's like let's just celebrate someone having the why to post their work out there, and if they ask for criticism, that's one thing, but our profession is very critical, and when I say ours, orthodontists and dentists, I don't. To me, it seems like the medical profession is more respectful of each of their specialties than each other than we are, and I don't know why that is.
I think it's because we're such a precision.
I have no idea.
It's like we're such missing tile people. I think that's a part of it. It's like we're missing tile people. We see one thing, we can't not see the missing tile in a wall. We just can't. It's like I can't ignore it. It's there. I can tell myself it's okay. The rest of the mural's beautiful, but that tile,
now when I see things like that, I'm not thinking, oh, that tooth should be rotated a little bit more. I'm thinking, wow, that looks like that patient has really underdeveloped jaws.
And that's exactly what I noticed more than anything. Yep.
More of a thorough exam because there's bigger and deeper issues here.
Yeah, and that's what a lot of orthodontists will, case will go up and someone will show this case where they gave them straight teeth, but they caved the lower arch completely in and didn't address the maxillary skeletal transverse deficiency. And if I question it and say, did you ask about airway? And it instantly, it's like, oh, not everything's airway, but did you ask? Did you screen them? And oftentimes I'll say to them, some people say, yes, I asked. How? What did you do? What did that look like? And rarely do they reply other than just I asked if they had a sleep issue, which I want to come back to in a second, some of what your diagnostics involve. But there's some people who need to take responsibility for that. And I fault our academic institutions and our leadership organizations, especially the AAO in this case. I think the ADA did a great job with that. Steve Carsonson was one of the authors, as a friend, and he's been on the show, and they did an amazing job. I think that was 9 years ago that they did that. It was amazing to make that statement. And basically, to summarize, they said you need to screen for patients, screen for airway in all patients. You need to work with medical and dental colleagues through referral when you detect an issue as needed, or provide evidence-based treatment in the attempt to establish a physiologic airway and breathing pattern. They didn't just stop at screen. Yeah. And that's where I have a lot of frustration. That's where I get very frustrated with the AAO. They just released an update to their 2019 white paper. The 2019 white paper, which I called out, and I actually wrote an article in OrthoTown that was very critical of it because it focused all on OSA. The title was Obstructive Sleep Apnea and Orthodontics. And anybody who knows anything about sleep medicine knows that airway dysfunction, sleep disordered breathing, is a spectrum of disease, which culminates in the end stage disease of OSA. So that to me was incredibly flawed, that the whole paper was on OSA. And so they did a good job making it about sleep disordered breathing. And I would say they actually were more emphatic about that. So I appreciate that. They more emphatically said that, like, this sleep disordered breathing really is a thing. Before it was kind of, well, is it really a big deal? Now they're starting to acknowledge the comorbidities. I mean, I don't know how they couldn't at this point. It's over the medical literature, but they're starting to acknowledge some of the comorbidities. They don't acknowledge the long term, meaning they make statements like most patients will outgrow their sleep disordered breathing and they become adolescents. So number one, the two right. And the two sources they cited were terrible references and won't get into it in great detail right now. But the statement that they made was that primary snoring and mild SDB do not appear to be strongly associated with progression toward more severe SDB. In other words, there is a tendency towards spontaneous remission of SDB from preschool years to adolescence. Now, I've had David Gozal. I interviewed him. I think his episode will come out like the week or two after yours. I discussed this with him. So for those listening now, listen to my interview with Dr. Gozal in a week or two. He blatantly says that is not accurate. But Hal, one of the references they cited two references. One of them was from a 2010 article from the Journal of Pediatrics, which in the paper's own discussion, it says, moreover, this is a reference that they cite in support of the fact that kids outgrow this. Mm-hmm. Moreover, SDB in preadolescents may not spontaneously remit, and a significant number will develop SDB when they are adolescents. That's one of the two references they cited to justify the statement. So, people think I'm hard on the AAO or I'm critical. I mean, also this paper, they had like 8 orthodontists and 1 librarian who collected data and research for them. Not a single physician was part of this document, not a single myofunctional therapist. I mean, it was all basically, everybody was just orthodontists. And I know multiple of the people that wrote it, nice people, nothing against them personally, but are they like the experts in dental sleep medicine and sleep medicine in general? So that's where I have a problem. And the other part of that is, they don't provide any guidance. It literally just says you detect this issue and you send it to the appropriate medical professional and then let them guide you regarding what to do from there. So much so that they said we shouldn't be treating a patient until they have a formal diagnosis of SDB from the physician. And I'm like, oh my gosh. So if we see the ADA got it right? Yes, you need to refer and we need to work with our medical colleagues and other dental colleagues as needed. But that doesn't mean that as an orthodontist or even a non-orthodontist providing early orthopedics, you can't go normalize that anatomy. I don't have to wait for like some label of SDB. I mean, give them a PSQ. Shervin's 2000 PSQ is a validated questionnaire determined to be as accurate as polysomnography in determining the presence of SDB. That doesn't mean I'm diagnosing them with SDB. It's outside of my scope, like you said with the septum, right? Or the turbinates. You're not diagnosing them with this, say, allergic rhinitis or this anatomical issue, but you certainly have the ability to recognize the abnormality, and then you make the appropriate referral. And my point is, I'm going to go in and help this kiddo grow regardless of whether they have a diagnosis of SDB, because they're deficient in width and not growing correctly, or their midface is retrusive and it needs protraction, or whatever it might be. Right. So I mean, in that, I'd like to hear what your diagnosis involves. But before that, if you could just comment a little bit about why you think, and I know you don't know, but just in your experience, you've been doing this for a long time, why do you think the orthodontic community is still so against trying to take any ownership of this?
I think that, just like you said earlier, they have very good systems of straightening teeth, and they make a really good living at it. And I'm not saying they're greedy. Most of the orthodontists that I know take great pride in giving people beautiful smiles. They really do. They're good people. Agreed. Like any profession, they're good people. They're bad people. Most orthodontists, most general dentists are really good people, and they want to help people. Yep. But you don't know what you don't know. And it is something that it's kind of like, I'm really happy living in this house. I love it. It's great. There's a house across the street, though. If I go inside that house, I may fall in love with it, and I may not ever want to come back to this house. So I'm just not going to go over there. I'm not going to go through that door. So why look into something when your life and your systems that you have are doing everything? You're living a great life, and I have a good friend that's an orthodontist, and he makes a really good living. His patients love him, and we talk about Airway, and he asks me questions, but he's not really doing that. And it's kind of like out of sight, out of mind. And I don't disparage them for not doing it. It's not that they're bad people, but I think that it's a profession that is so entrenched in the way things are done. And you would know better than I, but I look at when I had braces when I was like 11, 12 years old. And to me, I don't really see a whole lot of difference. And that was, 50 something years ago. I don't see a lot of difference in what is doing the orthodontics they're doing now that they were doing then. And they've got their system that probably wires have gotten better, materials have gotten better.
I was just going to say material science has advanced a ton, but the actual fundamentals and the diagnostics, no, it is. And as I spoke a little bit about in the talk at Airway-Palooza, orthodontics is not based in randomized controlled trials. It's based in observational data. It's based in clinical case studies and reviews. I'm not knocking it because that's not, Sackett said that is valid data. Those are valid studies. It's just, let's not pretend that it's all based on this pure, randomized controlled trial for everything we do. It ultimately is based on a lot of observation. And so there's not a lot of science behind orthodontics. And again, people jump on me for saying that, but I say, prove it. I published an article in OrthoTown just recently. I can put a link in the show that talks about the actual lack of true evidence basis, so to speak, in the sort of randomized controlled trial realm, which something doesn't need to have a randomized controlled trial to be evidence-based, but many people think that. So, and many people in orthodontics say a lot of what you and I do and think about Airway isn't quote unquote evidence-based because there aren't randomized controlled trials. Well, again, that's not the way it's meant to be, but let's just flip that for a second. Let's say that is it, right? Let's say that is the definition. It's not. They're standing in a house of cards. It's the vast majority of what's done in that profession is based on customs and everything from bracket prescriptions to, like you said, wire materials to wire sequences to doing IPR. There's no randomized controlled trials on this stuff. And so, nor necessarily do they need to be, right? But it's just.
You said at the Airway-Palooza, I'll never forget you, and I'll just be very broad here, but there was someone that had written a paper, an orthodontist had written a paper saying when the, randomized evidence base, this, that, and the other, this same doctor was the one that invented one of the major clear aligner orthodontic companies with no evidence that clear aligners would work at all. And they were, we know that they do work. Thank goodness. But when he came out with that, there wasn't any evidence based on that, and I just think it's kind of hypocritical that he was the same one that had written one of these papers saying that we must see evidence based outcomes.
Yeah, and saying that anyone who doesn't, I say it's public knowledge who it was, Orhan Tunkay. I don't know him. From what I've heard, he's an impressive guy. Director of programs, multiple orthodontic programs. He wrote an article in the mid-'90s in AJODO talking about that basically people who practice this unconventional, unproven orthodontics, which he was alluding to like early treatment. Airway wasn't even on the radar yet at that point. Even though Airway had been talked about in our field for many decades prior to that, this was a debate over phase 1 and phase 2. And like I was saying earlier, right, it's all about the teeth. And so he was saying that these unconventional approaches are quackery. And these people are charlatans who do this, and that everything you do needs to be based in sound research and data. And then you go to his website, and to this day, it has or maybe since I've been talking about this, he took it down. I haven't checked it lately, but it literally has a big banner on it that says his name and then creator of Invisalign, or one of the creators of Invisalign, which again is a little odd because it was created by business students at Stanford, MBA students. Yeah. But even so, he's clearly bragging about the fact that he was one of the early adopters. The first randomized controlled trial showing the safety and efficacy of Invisalign was in 2015 published. So again, it's like, let's drop the hypocrisy. Let's all realize that we're in this for our patients, right? And we all have to make a living doing this. So can we really back up and realize we may not be as smart as we think we are? I often talk about the Dunning-Kruger curve as well, right? A lot of us in dentistry, not just orthodontists, we've been achievers. We've been smart. We've been successful academically. We think if it's out there to know, we pretty much know it in our field. And we think we know everything about Airway. There was just a post in one of the Facebook groups And this guy was kind of going off on, the airway's not a thing. And someone posted something that said something about, and in it they said PSG. And the same person below said, what's PSG? I mean, Hal, you can't make this stuff up. I'm like, you're arguing over you don't even know.
You know nothing about.
Like, literally, you don't know the first thing about it. And I'm not saying this to be like critical of that person. I don't know the person. It's just that just shows again that instinct to try to, as you were saying, kind of defend your turf, and you don't want to be threatened. And I get it. Like, I used to get really angry about it. And it used to frustrate me. Now I look at it as I talked about in that talk, that tactile empathy. I look at it as like, I get it. And in truth, I was there. I wasn't trained this way. I didn't think this way. Yeah. And when I started doing this, it made my practice, it made it harder. It made it a lot harder because now I just spend more time in the exam room. And now all of a sudden I'm getting like 6-year-olds walking in my door, and a lot of them, and they take more time in the diagnosis and treatment planning. And a lot of times they do have hyperactivity and signs of ADHD. And so they're bouncing all over your new patient exam room. And, it's like, we just like bring them back when they're 12, and, they have their peer group around them, and they don't want to act up around their peer group. So they're going to say, be quiet and let me do whatever I want to do. I mean, that's kind of the way we think of it. We say they're not, quote unquote, ready for treatment. Well, are they not ready for treatment, or are we not ready to treat them?
Yeah, right. That's a great point. That is a great point, because if they're difficult children, they're going to be sick teenagers, and they're going to be broken adults. So,
right. And that's such a great point too, because we know these comorbidities last into adulthood, even if they outgrow it. Like back to that, like let's say they are one of them, because some do. Some, if it's like lymphoid tissue, the lymphoid tissue can shrink as they age. Let's say they outgrow it, right? Because the studies will show some do. Well, David goes, I won't tip it off too much because he's coming after you, has some comments on that as well. But the point is, damage is done. And they may not truly outgrow it, but it may seem they do, is kind of the hint on that one. But let's just say clinically, it seems that they have outgrown it. The damage is done. Yeah. They have cardiovascular damage. They have neurologic damage. They have behavioral indicators that will last them and come back to haunt them far into the future. So you may never know that's why those other things are happening, but the medical community is very clear. I mean, I could sit here and quote research for the next half hour on it, that these are not short-term comorbidities. These follow them. And so on that, getting into your diagnostics a little bit, and also I'd love you to talk about what you're seeing as these patients get to be into adulthood. What does it look like? And you can tie those two things together. When these kind of patients come, like, what do these adult patients with some sort of sleep disorder, what do they look like when they walk into your office? And what are some of your diagnostic tricks to help figure out what's really going on?
Well, we always say we'd rather treat sick children than broken adults. And we treat a lot of broken adults, but the point being, you get to it earlier, they don't become broken adults. And we put ALS in kids as little as 3 years, as young as 3 years old. We do tongue releases on infants to get the ball rolling. But what I see in children when they come in is they're a lot of them have attention deficit, and they're hyperactive. They have behavior issues. They have problems in school. And these aren't just problems because the curriculum is too hard. These are problems because they can't focus and they can't, be still long enough, and their mind is racing. And so we see children as young as 5 and 6 years old sometimes that are on amphetamines. They're on and that is so sad, because we know the research has shown that if you get on Ritalin at an early age, the chances of you ever getting off of it are very slim. Because there's not only a physical dependency, there's a mental and an emotional dependency on that too. So we see these kids with the dark circles under their eyes, and they come in, they have long faces, their mouths are open. They're just kind of lethargic, a lot of them. And that kind of just carries on into the teenage years and then to the adult years. And most of the adults that we see they either have a bed partner, or they themselves know they don't sleep well, or the bed partner is telling them that they snore. And then we start asking them questions, and they start putting two and two together that, you're not supposed to wake up with brain fog. You're supposed to wake up feeling refreshed. Many of these people have never ever experienced that because they never experienced it as a child. And the younger you are, the more resilient your body is to things going on. It catches up with you as you get older.
Yes.
As we were just talking earlier, our aches and pains from lifting weight. But when I have a child or an adult walk in, the first thing I start diagnosing from the minute I start talking to them, I'm looking at their facial features. I'm looking at their mannerisms. I'm looking at their skin tone. Do they have a healthy, vibrant skin? Do they have, rashes? Do they have scaly skin, dry skin? Looking at the dark circles under the eyes, because we know that underdeveloped maxillas, a lot of people have that because the orbital vein can't drain like it's supposed to. We diagnose before ever looking in their mouth. I have them breathe in through their nose really, really fast to see if their nasal valves collapse. That's not supposed to happen. And so we look at 4 zones, and we've added a 5th, the TMJ. But the nasal passages, that's zone 1. The nasopharynx, as that nasal passage goes back behind the soft palate, that's zone 2. The oral pharynx, as the airway goes behind the tongue, and then the oral cavity, that's zone 4. So nasal passage, the nasopharynx, the oral pharynx, the oral
cavity
itself, and then the temporomandibular joint. Now, I tell patients, if it's below that, that's out of my wheelhouse. But what we do, we take videos of patients walking. We take full postural photographs, because we tell our patients, we want to see everything. We have them point to where they're having aches and pains. We take pictures of that. And what we tell them is there might be an oral component to some or all of these issues they're having. There may not be, but we want to know everything that's going on, with you. We do a very thorough medical history. And we're not here to say, oh, you've got congestive heart failure. Well, I would recommend this, that, the other. We just want to know all of that. So as we're treating this human being, we're looking at every aspect of what we know how to do and how that might help them. We don't make any promises. But our diagnosis basically stems in these 5 zones. And in Texas, dentists can order sleep tests, but it has to be read by a physician.
Interesting. I didn't know. That's pretty neat.
Yeah, I can actually put in their review of findings that they have a diagnosis of upper airway resistance or obstructive sleep apnea because I have the sleep test and I have it signed and diagnosed by a physician. I mean, I've read enough sleep tests that I can diagnose it myself, but that's not in my wheelhouse.
Right.
So we have that there. And then maybe we have a report from the ENT about tonsils or the deviated septum. We do a radiology report on every full field of view CBCT we take. And so in that diagnostic, in that radiology report, it will say you have a deviated septum. I'm not saying that. I'm not diagnosing that. It's in the radiology report. The radiology report says you have a deviated septum. You have maybe a constricted right nasal passage, enlarged turbinates. I'm just showing you what we see. We now need you to see an ENT for final diagnosis and to see, an airway patency test of your nasal passages and then have them do their thing. So we try to be as thorough as we can, but staying in our lane. And our lane is really and truly those 5 zones that I told you about. And because what we do can have an effect on those. Yeah. What we do can have an effect on the shoulders, the neck, the hips, the legs as well. That's why we do our diagnosing from a whole body perspective, and then focusing and honing in here. But we're looking at everything, and we're not diagnosing, oh, you have a frozen shoulder or you have a torn rotator cuff or anything like that. We just want the patient to know that if they've got a crooked cervical vertebra, if their vertebrae aren't lined up right, and they've got these issues, that there could be an oil component. And, I've had a lot of patients that had no idea their C1, C2, C3 were, jacked up, but you can see it on the scan. So do I treat that? No, but let's get you somewhere that you can. And most of these patients require the expertise of, like I said earlier, 3 to 5, 6, 7 practitioners, not for the rest of their life, but to get them whole again, they have to have that. So my diagnosis is, my global diagnosis, when I see somebody with oral issues in the nasal passages and all that, I just have a global diagnosis. I'd say you have impaired mouth syndrome. I learned that from Felix Ayala. You have impaired mouth syndrome, and here's what I see, with subsequent ABC, this is what I see in there. If, I can diagnose periodontal disease, I can diagnose malocclusion, I can diagnose TMJ issues, I can have a diagnosis of their airway from a sleep test that I'm able to order, which is really nice in Texas that we can do.
Yeah.
But I would never diagnose from a sleep test without having it read by a physician.
Yep.
That's not my call to make. Now we may do another sleep test a year down the road and just compare, the numbers to where they were, but the diagnosis is made by the physician, by the practitioner that is their specialty, and it's just part of their plan and part of their part of my diagnosis in having them add that in there as well. So I'm very careful not to tell them I'm diagnosing you with this. This is what your sleep test shows, and this is what Dr. ABC has written as your diagnosis. If you want to get a second opinion, you can take the sleep test somewhere else and have them look at it as well. But this is the diagnosis that we have here. And do my TMJ diagnosing based upon what I see personally and also what I see in the radiology report. Since that's my area of expertise, sometimes I might see something on the radiology report I disagree with, and I'm able to say, the radiology report says this, but my diagnosis is this. But I would never do that with like cervical vertebra, with the airway, with all that. That's not my area to diagnose. But we put all of that together and we put it into a really nice plan for the patient so that, like, as I mentioned earlier, they can take this with them to any of their physicians that they go to. And so we oftentimes will have patients start, with 2 or 3 other doctors before we start what we're doing, because it's not about getting something in their mouth. It's not about throwing an appliance in their mouth. It's about helping them get well and whole. And sometimes there's a specific order that you need to go through, and so that's what we try to recognize when we do our exams on our patients. And we know enough about these other areas that we can see a correlation there, but diagnosing things that are outside of our realm, we don't do that, but we do send them to where we feel like they need to go.
Oh, thank you for explaining that. A couple things I want to highlight. One, ALF. People hear that, and my orthodontic colleagues listen to the show, and they instantly are like, ALF, it's just tipping teeth. You said in a 3 or 4 year old. So the thing is we've known for a long time that light forces. I use braces and wires in young kids, or you can use aligners in 3 and 4 year olds. You can use, if you put an expander in, you don't want to be turning it rapidly. It should be very slow and gradual. As kids are like silly putty. I mean, you don't need to be putting a lot of force. ALF is a light wire appliance, which is at that point really just helping develop the transverse. It's like a real light TPA almost of sorts. I know there's some different parts of an ALF, but or a light lingual holding arch. You're just starting to get some transverse development and trying to encourage proper tongue posture. People see horror stories of an ALF in an adult that got improperly activated, overactivated, and tipped teeth out of the bone, and they think an ALF never works. No, that person didn't know how to use it and used it incorrectly. I mean, anything from a hammer to a handpiece, you could have a person who knows how to use it properly and it works well, and doesn't, and it does damage. So, that just want to clarify that. The other one, posture. Thank you for bringing that up, because people don't think about that one. And that is huge. It is one of the single greatest indicators of an underlying airway problem in patients. And I want to get to, in a second, asking you more about the TMD side of things, since that's really your wheelhouse too. But Linder Aronson knew this back in the 70s. He published something in 1970. He had a first publication on this talking about how the posture of the neck, the cervical posture, was altered. You had a curvature in the cervical vertebrae. Well, why? Because these kids, to breathe, they're putting themselves in a CPR position, right? Head tilt, chin lift. I mean, that's why when you look at a mouth-breathing, snoring child at night, their head is craned on their pillow back to try to get patency. And then, because to look straight ahead, they can't walk around with their head looking up, they adjust their body posture to keep that focal gaze straight. And now you have altered spinal posture. So a lot of times I say, and this has been the articles, Chavez, Sabatucci, Okuro, there's numerous articles showing the relationship between pediatric sleep disordered breathing and or OSA, depending on which the study was, and altered excessive curvature of the C-spine and altered posture. And then as you take it down to adulthood, okay, so their C-spine's off when they're young. Well, now that adult has all sorts of altered posture. The other part of posture, exercise, I love. Anyone can do it. Not if you're driving or running on the treadmill listening to this, but at some point stand there and just close your eyes and bite down on one side, say the left, and see what happens to your body, your center of gravity, where you go. You're going to go left, and then switch and bite hard on the right side. You're going to sway a little bit to the right. So the way you contact your teeth, of course it impacts the entire neuromuscular system and your posture. And again, I want to come back to that more on the TMD side.
And we muscle test all of our patients. It's very simple. We have them, we put one tongue depressor, one thickness or maybe two thicknesses if they're really a deep bite, class 2. Okay. And we just have them close on it, and then we put
close on the front teeth.
Yeah, we don't instruct. We put it here,
kind of towards the roof. Okay, on the incisors. Yep.
We'll put polyvinyl in there. Take it out, trim it out, have them put it back in. We'll muscle test, and they walk better. Their posture starts correcting when they have that in. And that's a really eye-opener for the patient. But the muscle testing is what's the most amazing thing. We'll have them just simply hold their arm out, and with one finger, I'll push with them biting their teeth together. They can't resist. You put the open bite in, and we have them in a position where you do what we call pinky test. We have them bite on the thickness until we can't feel the TMJ being shoved back. And that's usually one or two thicknesses of a tongue depressor. Okay. And we do the bite at that so that they see an immediate difference. And a lot of them say, hey, can I take this with me? Wow. Yeah, sure. Go ahead.
Wow.
So yes, just getting to what you were just saying about biting on one side and biting on the other, it made me think we should start having patients bite on a cotton roll on one side and take a posture, and then bite on the other side and take a posture photograph, because you're exactly right. You close your eyes and you will start leaning to that side. Yeah. So the bite has everything to do with posture, and posture has everything to do with the bite as well. Yeah. And airway has everything to do with posture too. So it's all related.
It's a great example of how it's all related. So if you're looking at the jaw joints, what are some of the telltale warning signs in kids and in adults that we should be looking out for when a child would also maybe have an underlying airway issue? Or is it literally, I've heard some people say that pretty much the vast majority of patients with a TMD have a comorbid airway problem as well, or a concomitant airway issue. So where do you stand on that?
I would agree with that. I would agree with that. And what we normally see, very common, especially in younger people that haven't had the time frame for the joints to wear down, but we see distalized joints. So the space behind the condyles is much smaller than the space in front of the condyle. Okay. And it should be just the opposite. And the reason why is the mandible is being trapped and it's being pushed back. And so the muscles are pushing the jaw back to get it to close underneath there inside their small upper jaw. And so it's very common to see distalized condyles. That's the first thing that I look at. And then, once will you see that on your CBCT? You're saying you'll pick that up?
kind of be positioned more posteriorly when you have them occluding in CO on the CBCT?
Right. Yeah. Okay. We always have them occluding. We don't use a bite prop. We always have them occluding in CO, and I want to see their joint position the way that it is when they're walking around every day, because they're they're not biting on something. Their teeth come together.
Yep.
And airway, we don't put them in a chin cup because that puts their head forward. We have them stand with their shoulders back, ears over the shoulders. And for a lot of people, they said that's really uncomfortable standing that way, because they don't. We want to see what the airway looks like when their posture is as good as we can get it, because that's where I want to see it. I want to see their TMJ with their everyday bite and see what that's doing to it. And we see, as the older patients get, the more disfigured their condyles get. And there's always, I want to say always, not 100%, but over 90% of the patients with dysfunctional temporomandibular joint have an airway component associated with it.
Interesting. And when you address the airway component, have you found, as someone who early in your career was not aware of airways, none of us seem to have been early in our careers for sure, those of us who've been doing this for a while, have you been able to quantify a difference in sort of, I know you said there were some more failures back then, but has your approach to treating patients with TMD gotten easier? And yes. Okay, so you've noticed a difference when you get at the etiology or the comorbidity of airway. You're noticing that you're having better success on the TMD management side.
Right. Yeah.
Interesting.
Even if all we do is clear aligners to, just tip some teeth out. If they don't want to do epigenetic expansion, just giving them a little bit more room allows the mandible will always move forward. If I put a patient in an orthotic, I always use a permissive orthotic, meaning it doesn't force the joint anywhere. It just keeps the teeth from forcing the joint anywhere. And what happens is they always end up with on the front teeth or the mandible moving forward. And that's because they want to breathe. And a lot of these patients with just a dental orthotic that allows their mandible to move will actually start sleeping better. Obviously, it's not a cure for sleep-related breathing disorder or OSA, but they will start sleeping better because their mandible's not trapped anymore.
Not trapped.
So so there's a definite correlation between, and that's why I said early on in the interview, you asked me about what has this done for me personally in my practice. It's been liberating because it answers a lot of questions that 15, 20 years ago, I didn't really know the answer to it. The answer was always, we need to do something to your teeth to keep your joints from melting. And now we know that we need to give you a better airway and allow your mandible to move into its most stable physiologic position. And we present that to a patient, and if they don't want to do it and they continue having problems, now they're owning more of the issue than it being on my plate to try to stabilize a joint when the jaw is being shoved back all the time.
Right, fighting you all the time.
One of the reasons I had success early with treating TMJ is because not knowing, but opening the vertical dimension. I mean, Dr. Dawson used to say, you can't open the vertical in, more than 1 millimeter. I mean, I've opened, people 6-8 millimeters before. And when you do that, if they're not, if they don't have a really obtuse jaw angle, you improve the airway. If they have a very obtuse, that long face or the severe class 2, you got to be careful because
you can make it worse, right?
You can actually impinge on the airway.
Yeah, sure.
And I think that was the saving grace in a lot of my early successes, that we were opening the airway without even knowing it, to some degree by opening the vertical. I was never afraid to open people's verticals, because you put in an orthotic in their mouth that's 4 millimeters thick and they feel better immediately. That proves to me right there that you can open the vertical, because they can live with that and they can wear it full time. And that was another thing. All my orthotic therapy has always been full-time wear, because we want to get the teeth out of the equation. And so I really thought, for years that I was really getting to the root of the problem, because I was taking the teeth out of the equation and getting the joint stable, And I realized, well, the reason the joint's not stable it's not because of the teeth. They're, they're a factor, but it all goes back to a poor airway from an underdeveloped jaw. And of course, that's, as we talked before, that's not always the case, but in many, many times it is. I would say over 90% of the TMD patients I see are trapped.
Wow. I really appreciate you taking the time to go through all this. Honestly, it's been great. The time has flown by. I hope the audience enjoys listening to this as much as I enjoy doing it and listening to it, because it expands my mind and my reality as well. Every time I speak with someone like yourself, I just start thinking differently about things than I even already do. And I'm like, I hadn't really thought of that, or I hadn't really maybe processed that as much. And I think the more we can have these conversations, especially, I don't know if it's technically interdisciplinary in the sense that we're both dentists, but being that I'm an orthodontist, you're a general practitioner, I think there is an interdisciplinary nature to that for sure, by definition. So the fact that we can have these conversations and say, yeah, we are all really doing this for our patients. And I think that's where social media, especially and online, is just toxic, because I've tried to create with the doc community a little different environment on Facebook. So I put a link in, I think, every show to people if they want to join that. But it's for not just orthos. You don't have to just be thinking airway. They have myofunctional therapists in there and hygienists and people who want to think about a more holistic approach to patient care. And it's constructive. And I've had to step in a couple times when people get a little aggressive with one another and be like, no. We're not here to insult one another. We're not here to mock one another. We're here to learn. And we're here to be able to be a little bit vulnerable and say, like, I don't know it all, but can you help guide me through this? And then you get some really cool things, like orthodontists posting a picture of a 3-year-old and saying, what should I do about this? And that's growth. And then colleagues accepting them and saying, hey, maybe try this, maybe try this. That's what we need. We need to fight this fight together, because as you said, and as I've seen, because I get a lot of people that listen to this show that aren't in the dental and medical profession that reach out to me all the time and ask me, how can they find a like-minded dentist or orthodontist who can help them or their child? Yeah. So the public wants it. They understand that there's more going on, right? They understand that we have been hyper-focused on the mouth and need to think outside of that. It's time for all of us to take ownership of that. And you started doing that way before this was en vogue or commonplace, and is much more commonplace now. We'd obviously like to see improvement there as well, but the fact that you did it when you started doing it, it's just amazing. It's amazing that you started doing it. And I would often say sometimes those horrible events or tough events that happen in life happen for a reason. And look at how many lives you've changed. You've taken what happened to your dad and what you saw. Think of how many people's lives you've saved. I mean, literally, Hal, saved because of that. And so I give you such credit for channeling that into something that wasn't probably easy to implement. I can't imagine, it's years removed, so time tends to make us not realize it as much, but I can't imagine transforming how you and your wife practiced and how you approached all this was an easy thing to do, but you did it and you're changing lives. And I give you a lot of credit for that.
Well, I appreciate it. It was challenging, but well worth it. Well, I wouldn't change a thing.
Yeah. So
I just started doing it earlier if I had to change anything.
Right. Right. I know.
Day one, so I could help. We could help more people, but
and I hear that from so many people. Like, I wish I knew this sooner. And after I spoke at the Florida Association, I've had a bunch of people reach out to me, and many of them say, I looked at my patients this past week so differently. I have caught multiple patients with exactly what you were showing, and I never knew it. Thank you for opening my eyes to that. And Hal, that's everything to me.
That's great. Yeah.
That's everything to me. I mean, because that is that exponential effect that we can have when we just talk to our colleagues, respect one another, keep an open mind. And at the end of this, we're just trying to help our patients. And that's really, so the fact that you've done that, not only with your own 2 hands, but been teaching it and helping others as well is really great. And I've never met someone who, when they started seeing it, said, geez, I wish I didn't see this. It's always what you just said. I wish I saw this sooner. Yeah. I know with me, I look back at cases I've treated before I understood this, and I'm like horrified that I didn't understand it. I missed it. I mean, I think where those kids are now, they're adults, but like, oh my gosh, like I totally didn't get it. I totally didn't notice it. Or even adults that I saw that I didn't understand airway was underlying their broken down dentition. So I just started trying to fix their teeth and trying to balance their occlusion, right? And work with someone to adjust the TMD. And I'm like, oh my gosh, she or he had an underlying airway problem. And I never knew it. So, that's why I always say grant each other grace on that, because
Absolutely.
we all have those skeletons. We all have those cases we didn't treat, but don't let that hold you up. And I think you would agree with that, right? Don't let that stop you from starting to think differently, right?
Amen.
Yeah. Well, how can people reach you if they want to reach out to you or find more about what you're doing?
The Stewart Center for Optimal Health.com. And that's our website. We have a lot of information on there. So the Stewart Center for Optimal Health.com.
Awesome. All right. Well, Dr. Hal Stewart, thank you so much for spending this time speaking with me and
it was an honor. I appreciate it. I really do. Thank you for having me.
Thanks so much. And we'll be in touch, I know, and we're seeing each other, many more things. All right. Thanks, Hal. All right. Take care. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.